You know,
wow, that got very, very deep.
I mean, because I always think about.
Are you Batman? Like, are you like what just happened?
It's the
there?
four concepts
it's
of
like a very weird turn.
No.
All right, welcome to another episode of the OuchCast. I'm Neal, Rakesh. I'm joined with my co-host today, Dr. Gulati.
Hello, everyone.
How you doing?
Excited to be here. Thank you for calling me
Nashville?
doctor. I appreciate it.
You enjoying Nashville?
Yes, I have. I love Nashville.
Music
City.
You've been here a lot. I know you love music, right?
I'm into music. I've got a small little band in the city that's hopefully going to resurrect itself.
And this is like an amazing place for that because
the music scene exploded here probably in the last decade and a half. It's just grown substantially. It was cool in Austin. It's cool in Nashville now. It's just watching music grow and having all these different genres in one place has just been a really cool experience here.
All right, so let's get into it. We're talking today about minimally invasive spine procedures. Now this is
perfect segue.
Now this is an interesting topic when it comes to pain because it's kind of a burgeoning field. There's a lot of new things out there, and I think there's a lot of intricacies to it. What's obviously this is a large point in a lot of the FIPP conferences. What's interesting and why should people be looking at this? You know,
when I started as a physician, we were really targeting needles into the disc, maybe putting some cement into the vertebral body. That was minimally invasive spine about 15 years ago. Now we've really taken some of these things that are really complicated surgeries and really simplified them and made it safer for patients. And it's a revolution. Just being able to do some of these clever things with smaller devices, safer devices, smaller or non-existent incisions, really has revolutionized. Probably the most impressive thing is the expanse of the field. There's so many new technologies, there's so many new options for patients, but also something that physicians have to learn and be trained at appropriately. That's probably where we are at with this field right now.
Yeah, that's an interesting thing because a lot of people, when we conventionally think of a lot of things that people are trained in pain, it's injections, medications. This is kind of a whole new thing. Like there's a lot more surgical expertise that goes on here. And that's a little bit different. That's not a normal thing that you're seeing.
No, we were talking about pain, and now we're talking about stability. These are different principles from really orthopedics and neurosurgery, physiatry, really thinking about pain management, but actually solving problems anatomically as opposed to treating the symptom only.
Yeah. So, basically, I got a lot of questions. I want to know what are the different types of things that exist. I want to know when do we do it, and how, as you're saying, this is a new thing that's not classically taught to a lot of people. How do people get involved in it? How do people get comfortable with it? And what are the common things that people end up having mistakes with it?
Well, I hope our guests really help us with that today too.
Yeah, who you got for us? I'm excited. We got
some really young and entrepreneurial colleagues of mine. I've seen them grow over the last few years. It's really been a pleasure to work with these guys. We got John Akhnoukh, who's really built a great practice, really brought some of his innovations to the Long Island area in New York, the greater New York area. And then we've got Dr. Valimahomed, who I've seen over the years become one of the pioneers in this field. And he's got a burgeoning practice in New Jersey. So we got Northeast represented today. I think they're going to really fill us in about some of these questions that you have. And really, to do this appropriately, we really need our new generation to really help us hone in the right skills necessary for the success of this field in pain management.
Yeah. Welcome, guys.
Thanks for having us.
Yep, thanks.
How are you guys enjoying the conference?
It's going well so far.
Happy to be here, beautiful weather, 85 degrees, music capital of the U.S. here. It's vibrant.
Just to let people know, MIS is done in the operating room, not outside of 85 degrees.
Cold temperatures are better.
Yes.
So tell us, we're just talking about it. Tell us what exactly is MIS. What does that mean in the pain world?
Yeah, I mean, so MIS is minimally invasive surgery, and so this can mean a lot of different things. What's really exciting for me, and I think you kind of hit the nail on the head, was you have the ability to intervene now at this point and change disease pathology rather than treating the end symptoms of it. And so for me, part of the reason I went into interventional pain medicine was to be able to do something about the problem at hand. So as a physiatrist, we become very good diagnosticians, but oftentimes I found myself referring out, send to anesthesia, send to neurosurgeries, send to orthopedics, but I became a physician to help people. And so,
back up, like you were saying that you're a physiatrist in training, and obviously I know this because you were my senior by like 2 years, and I think that's an important thing because you're doing a lot of these highly surgical procedures, and you did physiatry. That's not something that people would classically say when we were in training. That's not something we learn on the wards.
Absolutely, and I don't think it's something that people necessarily know they have access to as well, right? Or you may find that you have an interest more towards an interventional type of field, and so that's what made me gravitate towards pain. But then I quickly realized that there's actually much more that is actually available to us, but you have to go about the right ways of obtaining the training to feel comfortable and to be competent in that.
John, what do you think? You came out of a great program, couple of years. I'm pretty confident you didn't have...
Great program? Your program. Wow. just veiled a great program. Just an arbitrary great program. What program was that?
It's in America. But you didn't have exposure to a lot of these things. I mean, we talked about it. It wasn't really necessarily even available. First of all, what got you excited? But, what kind of things do you have to do to make this successfully and safe for the patient that you're seeing now? So, yeah, you're right. I mean, we did at least open up the conversation at our institutions during fellowship, and I think that was an important thing to do. A lot of these procedures obviously have a little bit of a political background, not always easy to get into the academic centers. But you guys did a great job in at least acknowledging its existence. The way that I'm seeing pain management evolve is similar to how cardiology and radiology has evolved into an interventional field, whereas they were doing, open heart surgeries more frequently in the past. Now there's a lot of procedures that are essentially able to be done interventionally. The same thing with spine. I believe that there are a lot of cases that don't necessarily need to go from an injection overly to a major, fusion surgery. And we're finding all these steps in the algorithm to treat the underlying, mechanical problem. It's obviously tough because in most academic centers and most fellowship programs, you really aren't getting as much exposure. So the idea is to gain as much confidence and comfort with the fluoroscopy machine and know how to use it as extra eyes on the inside. Once you've gained that ability and you feel safe using that and understand the anatomy, it's easier to go into a lot of these courses and learn some of these interventions that we're utilizing the fluoroscopy to do similar treatments to what the surgeons are doing when they're able to decompress a nerve. That's a great point. Just knowing the exact X-ray imaging just to guide some of these simple procedures that you may be learning, but apply them to a more complex procedure. I think that's probably something that we've missed and maybe need to focus on in the future.
Yeah, so it's like a barrier of skills that you need to have. I think people oftentimes they go into fellowship and they think that if I learn like the sexiest things, that's like an element of being very, very good. But it's oftentimes like learning the building blocks of it. So I was just going to ask you about that. Like, what are the kind of like the barrier to entry? What is the baseline skills of things that people should understand before they start getting into minimally invasive spine procedures? What's the most important thing to learn?
Yeah, so I think you guys have already highlighted this. It's anatomy, right? Understand your anatomy, understand how things should go, right? And understand what are the potential complications and risks, and can you manage them? And how do you at least recognize them if you cannot manage them? I think sometimes it's very interesting to me. I'll talk to other colleagues and be like, well, you can't necessarily manage that. And I'm like, well, okay, fine. Mr. Spine Surgeon. But if you accidentally nick the lung, you're not going to manage that either, right? You're going to call in your colleague. You're going to call in, cardiothoracics. You're going to call someone else. We all have our lifetimes. The idea is that you understand your limitations, what you're competent at, what you can do comfortably, how you can help, and where you kind of fit into this algorithm and how you can help patients.
Yeah. What are the general things that you can do with minimally invasive spine? Like what are the types of things that you're fixing, and how are you doing this? How are you accomplishing this?
Well, the spine, at least when it comes to the spine, obviously it's a very complex structure with multiple parts.
Yeah.
And that's one of the things that we need to discuss with the patient on a first visit, is that there are many sources of back pain, and to a degree they may get a certain percentage from this source versus that source versus that source. We're able to do a few of the things that the surgeons are able to do using minimally invasive techniques through small incisions where we don't have to dissect other layers beneath the skin that allow us to essentially decompress the nerve by either removing part of the disc. We can also do an ablation of the disc. There are also procedures of ablating the vertebral body because a lot of times when the disc breaks down, the disc material can actually enter into the vertebral body and gets picked up by that set of nerves. And that's usually
like when you
extrude
a disc, essentially.
Extrude a disc, but also just disc degeneration. Even if it's not extruded, the disc itself breaking down with the end plate broken down, that disc material enters into the vertebral body, which also is we refer to as vertebrogenic pain. So that's another thing that we treat, and there are ways that we can do fusions also, but posteriorly, where we don't necessarily have to do a major dissection.
So how do you choose, man? So many cool things. I don't know. Last time I saw an MRI, I saw all those things you just described in one person.
And so that's you do all of them.
Yeah. But I mean, seriously, this is very important, right?
So,
we're trying to figure out.
This is what comes down to foundations, right? You have to have a strong foundation and strong diagnostic skills, right? Imaging is going to show so many things. It doesn't mean you necessarily need to treat it, right? And so you have to, talk to your patient. First and most important thing, get your hands on them, and then combine that with your imaging findings. And like you said, there's a myriad of things that we can do now. And there's never the unicorn patient that just has one thing. Or if there is, it's not the majority of the patients. So it's your job to kind of figure out what's the most likely cause and to attack it. But I think what's really nice about all these options we have available, we're not only stuck now in terms of trigger points, facet injections and ablations and epidurals, we now have the ability to decompress some of the ligaments, place a spacer to prevent collapse of the central canal stenosis. We can perform a minimally invasive fusion without doing a large incision via X-ray guidance. We can fuse the facets. We can burn the nerves inside the bone and do a basivertebral nerve ablation.
All these things, and we're friends with orthopedic surgeons. We are friends with neurosurgeons who do fusions and do endoscopic. How do you communicate and balance that you can do some of the things that other surgeons can work with you? Like, how do you?
Or you're like stealing all of their procedures.
Yeah, in medicine, we face a lot of these.
How do you play in the sandbox together?
Yeah, exactly. I know the kids can do it. What about the adults?
I think it's communication. It's communication. It's education on both sides. I think. For me, at least in my practice, there are patients who will self-select in the first place, right? They've already decided they're not going to go to surgery. But just because they've decided they don't want to go to more conventional surgery doesn't mean that they should be placed on opioid pain medications. And it doesn't mean that they should have, forever non-ending epidural steroid injections. So there are treatments that we can kind of offer these patients. There's also patients that have many comorbidities. And I think that's really where, for me, that's my niche. There's patients who are maybe too old or can't stop blood thinners or high surgical risk. And now we're introducing procedures that may have a baby aspirin size incision or 1 centimeter incision. And we've reduced surgical risk. We've reduced hospital time. We've reduced anesthesia time. And so now we have an option that overall, looking at their total health perspective, gives them possibly a better option. But at the same time, to your point, we have to recognize maybe where we may have limitations or the procedures that we have to offer has limitations, and clearly recognize that and explain to our patients that what we may have to offer may not address all of the issues where conventional surgery may be the best option.
John, any tips for a young physician that's working with orthopedic surgeons, how to introduce some of these concepts? Like
Yeah, I have to agree. It obviously can get a little tough, and depends. Every personality is a little different, especially in the surgical field. I think it's really drawing boundaries. So with a lot of these procedures, I really try to stick to certain indications. So with the minimally invasive procedures, typically, obviously there's certain things that our surgical counterparts can't really take care of, like an intraosseous basivertebral nerve ablation. They just don't do those procedures, at least not as of yet. But other things like discectomies, posterior fusions, I try to set a criteria first that will allow the patient to succeed. So I'm always choosing a subset of patients that have certain criteria that usually have findings that are not extensive. So typically if they have a spondylolisthesis or a severe disc herniation, to a certain degree. So like if it's more than a grade 1 spondylolisthesis, typically those aren't patients that I'm doing a discectomy on. So we need to work with our surgical counterparts to identify, okay, this is a more advanced case. Even if my procedure may give them temporary relief, I know that this patient's going to be in the OR with you again. So I need to be realistic. We're not going to just do a procedure on a patient just to appease their feelings, but at the same time give them
it's almost like you need a spine board meeting with your surgeon and yourself and saying, like, we have these procedures, you have your procedures. Which one should we consider for this particular patient? That might be a more cordial way to kind of guide us in our field, because I think there'd be some there's some barriers to that when you see orthopedic surgeons collaborating with pain doctors as a result.
I mean, I think there's also reasons where you should know that what you're probably doing isn't going to be the full solution. So for me, some of those big things are, do you have, progressive neurological deficits? Do you have saddle anesthesia, incontinence by bladder, right? So or a foot drop, right? If my patients have any of those things, for me, I tell them, listen, I'm not the right guy. Can we do a procedure? Yes. Is it going to be probably the best option for you? No. And therefore, it's the hardest thing is someone coming to you and tell you they want a specific procedure, but you having to tell them, no, this isn't the best thing for you. I have to say it's much harder to do that than it is to try to tell someone they need something to do.
Just to change gears, like you've said so many good things, and we talked vaguely about education, but let's get nitty gritty and specific. What do we need for the new fellows that want to do this? And they might be every fellow, but some of them will. What do we need to have a minimum criteria, so minimum access to, so we can get this done right, so we don't mess up the field?
Yeah, and specifically, just to kind of summarize everything for everyone, it's so the procedures we're talking about decompressions of the spine. We're talking about fusions of the spine, discectomies, ablations that could be of the disc, and then there's even SI fusions. So these are kind of the procedures that encapsulate minimally invasive spinal procedures. Is that right?
And kyphoplasties.
Kyphoplasties.
Yeah, so facet-related endoscopic rhizotomies. To be honest, like you were saying, I mean, it's just so many options now on the table that it really does require you to really evaluate the patient. And I think that's one of the toughest things. But there are a lot of options to treat lots of sources of back pain, neck pain.
I know a fellowship is open in this. Specifically in this field now, so sub-fellowship. So,
I mean, I would say at the very least, we do need a little bit more surgical exposure. At the very least, you need at least a month of that, working with our orthopedic and our neurosurgical counterparts. Though I do see interventional pain evolving because of the vast amount of tools that we're given, to a point where in the future, just like cardiology and radiology have a subspecialty in interventional radiology, I feel that the field may require additional time at some point, an additional year, just to focus on this. Whereas some patients fellows may not want to do these procedures, and they'd have that option whether to continue on or not.
So John's saying he wants to come back for fellowship.
Just one more.
Like, one more year. So I'm also hearing there's a lot of ultrasound that you need for these procedures. Is that right?
Yes. Actually, funny that you mentioned ultrasound, because, our surgical counterparts don't know how to use that tool, and I think it's such a powerful tool. Initially when I was learning discectomies, I was actually, and again, this was post-fellowship, I was taught to put my hand under a fluoro machine to retract the trachea and the carotid and to go in between. And I told myself that's not appropriate, first of all, for the patient in terms of their safety, and also for my hand that's going to be fluorid for the next 30 years. So ultrasound really is a tool that we can utilize for patient safety and to get more accurate results. And essentially that's one of the reasons why we pushed for that with cervical discectomies to be utilized in addition to the fluoroscopic and endoscopic techniques.
Oh, wow, so you do a combination of imaging?
Yes.
Yeah.
To get back to your question on the nitty gritty, like what do you need? And I think I think you have to choose, if say you're a resident and you're looking towards this and you want to go into this type of field, I think you choose a fellowship that's going to give you a lot of hands-on hours in the OR, right? You need some surgical experience is the real truth, right? You need to know how to manage bleeding. God forbid, should it happen, you need to know how to suture. These are some basic skills, which I think we all kind of have, but it has to be brought to the forefront. This has to be something that, that's not just a one-off for you. You need to be proficient in it.
We need to recognize orthopedics minimum 5 years. I mean, this is really what they're
right.
doing.
Yeah, and they've been doing that all 5 years, right?
That's how good we are.
And if you,
The neurosurgeon 7 years.
But and to that same thing, lean on that knowledge, right? You're in training. Go spend a day with interventional radiologist. Go spend a day with a neurosurgeon. Go spend a day with a spine surgeon. There's a lot to learn by seeing these procedures done open, because then you get a better anatomical understanding of what could potentially go wrong. What are the neurovascular structures which are next to you? It's one thing to read it. It's one thing to do under fluoro. It's another thing to visualize it and assist in this type of surgery. In terms of an hours, right? I think you need to go, when you're first starting off, go to as many courses as you can. ASRA-PMUC has some great hands-on training, and there are other industry.
Shameless plug of.
Of course, it's a shameless plug. Look at where we are.
He's like, I'm teaching that.
Now comes the logo right here.
And you can follow me at this private practice.
But also, you partner with industry. I mean, these courses are available, and they also have experts in the field to lean on. Spend a day in the practice of someone who's already doing this, get an idea, and see 9 cases back to back and understand what it is to do this procedure and get proficient in it.
That's
and when
a
you
key
do your
point.
first procedure, there are people that can, mentors or people in your community. Don't be afraid to reach out to them just because you're quote unquote competitors or from a different institution. We're all part of one family in essence, and there's plenty of people and patients to go around. It'll probably help you in terms of your networking in your area as well. But get comfortable, and your site of service really matters too, right? So when I started off doing some of these bigger procedures, I would do them in the hospital. When I'd have you could have a surgeon come and kind of check in on you if you had a bigger procedure. Or when I did it in the ASC, I'd have, one of my colleagues kind of, be there for the first couple.
Yeah.
And there's no shame in that. I mean, I think that actually
that's
shows
very
growth
important.
more than anything else.
Education doesn't
if they're
end at
just sitting
fellowship.
and you guys get to have a great conversation and shoot the breeze, that's what it's about in the first place.
Like I tell people, education starts at the end of fellowship.
I think so. I think someone told me that. I remember they said the first year of being an attending is real fellowship.
That was me.
That's honestly what, because you don't have someone that tells you, oh, can I do this? You're like, you have to make that decision yourself.
But I think Ali actually brings up a good point. For a lot of these institutions, especially the academic institutions, there's a lot of red tape around these procedures for the time being. It's not a bad idea for these fellowship directors to reach out to some of the private guys around them and see if there's any ability to expose your fellows to these procedures. I know that.
I think
Easier
calling
said than done.
calling you out. He's like, it's not. It's,
Send them
as he
over.
looks right into his eyes, it's
Send
not
them
hard
over.
to do that.
Well, we don't deviate from the ACGME guidelines.
Okay, of course.
So just to kind of get it all together. So basically, the key thing with any of these procedures, anatomy. That's obviously everything in pain. Fluoro is a pretty big thing with a lot of these procedures, and obviously understanding fluoro safety, radiation, and trying to do good practices with that. Suturing skills are super important with this. And then to some degree, I think a lot of these procedures are based off a lot of other procedures. So comfortable with the basics of the pain procedures are always important. And then as one of the most important things you pointed out, Ali, was having someone to shadow, going to different places like IR, orthopedics, neurosurgery, learning the skills from them. And then when you actually start doing this, having someone to talk to that's done this, that has kind of a huge background in this, or could even come in with a case for you and kind of go through that first few starting cases for you to kind of develop that comfort. And then you also did say, Ali said this, come to WAPMU for
Sounds like
training.
2 weeks and you're done.
Yeah, that's all you need.
2 days.
That's it.
Just one weekend.
Yeah, one weekend with Ali, and that's all you need.
No, but great points. I really think seeking out your own education. This is the field right now. It's where we're at.
And get some hands-on, right? It's one thing to go to a course or go to a book, but actually get your hands on, do it on a cadaver, right? And be the one who does the procedure. And I don't want to make it seem like this is some big overbearing thing, because a lot of these procedures are exceedingly simple, actually. But I think when you're first starting off, especially those first couple cases, those are some tools you can use to your creative credence to kind of help you feel comfortable. But I bet you 9 times out of 10, you're gonna be right up there, just kind of getting right in it. And you're gonna realize how rewarding it is to actually change disease pathology. Have your patient standing up straighter. They don't come back to you anymore for epidurals. It's really rewarding.
Feeling.
It's really
Fixing a
rewarding.
problem as opposed to hiding one.
Exactly.
Right? A patient the other day was in the hospital for in and out rehab multiple times. I saw him the first time, fractured their back, did a kyphoplasty, 10 out of 10 pain, on opioids, off the next day, walking around. I mean, that's like truly rewarding.
Let's take it to the future. What's missing from the actual techniques, devices? What gaps do you foresee, and where do you guys see maybe the innovation that either you or your colleagues can provide? What do you guys see in this? I mean, obviously, we're going to do this. More people are going to do this, pain medicine, whomever else. But where are the gaps, and what can we address to make this better in the next 5-10 years?
So, I think just in general, the techniques that we use nowadays are mostly fluoroscopic and ultrasound guided. I think there needs to be a level of comfort with the endoscope. That's really going to be a huge part of the movement of these interventions to becoming more established in the future. With us having eyes on the inside through an endoscope, in addition to the fluoro and ultrasound, we're really utilizing everything that we can to see the anatomy, to be able to treat the patient in a safe manner and in an efficient manner where they're actually getting good results. To me, that's the most important thing, because with the endoscope, we're now actually performing a surgery without, I wouldn't say it's officially directly, because we're not making incisions, but it's the closest thing to a direct visualization of what you're doing. And that's the idea, is that we're creating these interventions that utilize these small incisions that allow us to get in without dissecting all these layers and decrease risk of infection. And like you had mentioned before, Ali, the patients are recovering a lot quicker. Cost of hospital stay is low because they're not staying overnight. Yeah. They're returning back to work. So in terms of this idea of justice in the medical,
wow, that got very, very deep.
I mean, because I always think about,
are you Batman? Like, are you like, what just happened?
It's the
there?
4 concepts
it's
of
like a very weird term.
No, the reason why I use that term is because it's one of the 4 terms for the ethics of medicine. Justice, the idea of utilizing.
5. Wow.
No, but it's the idea of like cost effectiveness. Right, that's the idea behind this.
Yeah.
And I think once the insurance companies realize that these are not only effective, patients are doing well with it, and it's costing less, I feel like we're really going to feel our presence.
Ali, what do you think? Next innovation, what do you would focus on?
Yeah, so I still kind of just have some questions about some of the innovations we have now and what's the best way to do it, right? So for some of these devices, there are multiple ways to skin a cat, right? And maybe they all survive, maybe they all do well, but is there one that works better? Is there one that, we use for a specific type of pathology when right now we're kind of using them all kind of ubiquitously? Or is there a certain order we should be going in? So let me get more specific.
Open fusion versus...
Yeah, and coming back to the open fusion, so my question is, with some of these things is, so it's minimally invasive, and to what role do I see myself fitting that? And so I would love to do it for everyone, but it's like also kind of recognizing, well, some of these surgeons may be able to do a minimally invasive surgery and attack multiple levels in a shorter time period. Just kind of the flip on this, right? What is we think we're doing the best thing. I'll give the opposite argument here, but the question then really becomes like, well, if we do multiple minimally invasive surgeries, was it better to just do it once? Would sometimes be the argument. I don't know the answer, and I think it depends on the patient. But if we're intervening earlier with the minimally invasive problems, I bet you that we wouldn't even get to that question. And so my hope is that it gets integrated sooner into the fold. But again, especially with the fusion, I guess fusions were huge before, and pain medicine physicians specifically touted, that we shouldn't be doing, hence failed back surgery syndrome and spinal cord stimulation. So now the pendulum's kind of swung, and now we're on the fusion side of things. And so I think it's kind of interesting to see where we're going to go and how perspectives change, at least with treating. Now, the one thing I'll say with fusion for the spine that really interests me is that is something specifically in the past few years which I've seen kind of explode in terms of a treatment algorithm. I think discogenic pain is something that was very much ignored previously. It was either the facets, stenosis, or a herniated disc. But looking at the basivertebral nerve as a diagnosis, looking at degenerated disc, and now these options about we didn't even talk about, right, injecting different types of substances into the disc, or burning the nerves around the disc, or fusing. How do we? I think there will become a consensus guidelines, and I really hope that gets developed out, and I hope that we are good stewards of this and go ahead and try to figure out the best way to do it. Because right now, like you said, you look at that MRI and you have a lot of options.
Yeah, the title should be "What Happened to Morphine."
It'll make a resurgence. Give it 10 years.
I think that's a good place to call this. I mean, it's just to kind of get everything what you said at the end. So one of the most important things that you brought up in terms of just the pitfalls of it was essentially the types of imaging and pre-opping the patients. And how do you plan those things? 'Cause that's a surgical mindset, as Amma was saying. That's not something we classically say teach in fellowship. So that's a different mindset of approaching MIS with that understanding that it's not the procedural aspect that's the hardest part. There is also a when do you do it? What patients do you select so you avoid those complications of I need to take something out because you're choosing those ideal patients.
Just like drugs, the hardest part is to say no.
Just say no.
All right, we could probably do this for like another hour, but
you know what, Ali and John, you guys have been great. It's been fun to watch this field grow with you guys. I hope you guys are great stewards for MIS in the future and really do your best to try to get the new generation ready and doing these things correctly.
Excited to.
Great. Thanks for having us, guys.
Thank you.
Yeah, thanks for coming on.